Hello, everyone, and welcome to this evening's Power Hour webinar on crisis management. My name is Dr. Jennifer Nathan, and I will be co-moderating this session with Dr. Bob Pyatt as we are co-chairs of the Power Hour webinar series. Before we get started, we would like to go over a few items so you know how to participate in this evening's event. Kat, do you mind advancing the slide? Thank you. So on this slide, you'll see a screenshot of what we call the attendee control panel. You can locate this in the upper right corner on your computer desktop. So there are just two things that I wanted to point out about the attendee control panel. So when you first joined the call this evening, you had two choices on how to listen, either through your computer or phone. If for any reason you would like to switch, you can do so by going to your attendee control panel, which is here, right here. And if you go to the upper portion of it, here are your two options, computer audio and phone call. So you can click on computer audio. If you decide to use computer audio, we do recommend using a headset to improve audio quality. If you click on phone call, if you look over here, this is what will come up and you'll see the phone number, access code, and then PIN that you would need to call in. The second thing that I wanted to mention is towards the end of this webinar, we will have a Q&A session where you'll have the opportunity to ask questions of our faculty. There are two ways that you can ask questions during this webinar. So again, using the attendee control panel, if you go to the very bottom where my cursor is here, this box is where you would type in your question. Once you've completed putting your question together, you hit send and your question will then show up on our end and we will then ask your question for you to the faculty. You can actually submit questions throughout the webinar, but we won't specifically be asking them until we get to the Q&A session. The second way that you can ask questions is verbally, and you can do so by using our hand raising tool, which is located right here. So if you click on this hand icon, essentially you're raising your hand on our end, and when there's an opportunity available, we will then call your name, unmute the line, and then you can verbally ask your question of our faculty. So now I would like to turn things over to Dr. Pyatt to introduce tonight's faculty.
Next slide, please. Thank you, Jen. I would like to welcome everyone to this evening's presentation, and I'd like to introduce Jim Rawson and Bill Thorwarth. So Jim Rawson graduated from Tufts Medical School in 1989 and did his internship at Lemuel Shattuck Hospital and completed his radiology residency at New York Medical College in 1994. Dr. Rawson completed his training at the Mallinckrodt Institute of Radiology at Washington University and did a fellowship in body MRI there. Jim served as chair of the radiology department and imaging department at the Medical College of Georgia in Augusta University for 17 years. During that time, he included patients on radiology equipment installation and upgrades and other renovation projects. Dr. Rawson served as president of the adult medical staff for 3 years, and he served a 4-year term as a member of the CMS APC advisory panel, where he chaired the CMS subcommittee on packaging. Currently, Dr. Jim Rawson is serving as president for the AUR, the Association of University Radiologists. He also serves as a board member of the Board of Chancellors for the ACR and serves as secretary-treasurer for the ACR. He serves on the editorial boards of the Journal of the ACR, American College of Radiology, and Academic Radiology. Jim's primary research interest is health policy, process improvement, and innovation. And he currently serves as Vice Chair of Operations and Special Projects at Beth Israel Deaconess Medical Center in Boston. Our other esteemed speaker tonight, Dr. Bill Thorwarth. Dr. Bill Thorwarth completed his undergraduate and medical school education at Dartmouth. After training in internal medicine, he entered his radiology residency at the University of North Carolina. Since finishing training, Bill had been practicing diagnostic and interventional radiology with Catawba Radiology Associates in Hickory, North Carolina. And during his nearly 30 years in practice, Dr. Thorwarth became very active in a number of radiology and medical organizations. Bill has served both at the state and national levels within the ACR and ascended to the ACR Board of Chancellors from 1998 to 2004 and chaired the Commission of Economics and served as president of the ACR. In addition, he served the AMA as a member of the CPT editorial panel, which he chaired from 2007 to 2011. He was appointed to the RSNA R&E Foundation Board of Trustees and most recently was elected to the RSNA Board of Directors, serving from 2009 until his recent selection to his current position as CEO of the ACR. It is quite a pleasure to introduce both of these gentlemen tonight. Thank you. Next slide, please. Okay, Jim.
So I'm going to be talking about crisis management, and the perspective that I'd like to offer is lessons that we can learn from disasters and from crises. And I'm just having trouble advancing the slides. Here we go. So what I'm going to do is I'm going to focus on some organized approaches on how we can prepare for disasters or crises. And I'm going to discuss a little bit about what radiologists and practices can do to prepare for future crises. When you think about the COVID-19 pandemic, one of the questions you might ask yourself is, why should we try and learn from a once in 100 years pandemic? And I think the answer to that is that there are a lot of common elements that disasters have, and there are some things we can probably learn from this crisis that would help us prepare for the next one, but also that crises and disasters do actually tend to lead to practice changes. And this is an opportunity for us to learn from that as well. Next slide, please. So if you think about your emergency departments, they probably have done some planning for disasters. Next slide, please. But the disasters aren't just the pandemic we're in. There are multiple different kinds of disasters. They range from the natural disasters that we see sometimes in the news, hurricanes or floods, to having an active shooter in your hospital. There may be industrial events that are in your neighborhood or your region that ultimately affect the care that you're trying to provide. And in a profession as IT intensive as radiology, you should really think about cyber attacks as a potential disaster as well. Next slide, please. The other thing to consider is that you may actually have more than one disaster occurring. For example, a flood that occurs in your region might take out the first floor of the hospital, but if that's where your data center happens to be, your data center or your power supply for the hospital, you may lose power, you may lose PACS, you may lose your EHR. Next slide, please. So let's think about what disasters might have in common and how we could actually prepare for disasters in the future. Next slide. So in this 5-circle phase diagram, you can see that the disaster is one of the phases, but that there are 4 other phases to consider. You do have the opportunity to often prepare for a disaster prior, hopefully, to the event. You then have some type of response. There is then a recovery period, and then there's an opportunity to learn from that and do some type of prevention or future mitigation. Next slide. So if we think about the preparation side, in the long-term planning, we certainly can do disaster drills, and you probably have been part of those at your hospital or in an emergency department. There also is some training that you could take advantage of. Many radiologists are involved as leaders in their medical staff, and hospitals often have incident command center training that they provide for their hospital administrators. I was fortunate when I was medical staff president to be part of that training as well. You also can think about contact information that you might want in a disaster. The time to be looking for someone's phone number or email is not in the middle of the crisis. You'd like actually to have a list of all the physicians, your technical staff, your support team, maybe your vendors. You might even want to look at other resources that you might want to have access to and have that type of communication or contact list available. As you have an event that's imminent, you do have the opportunity to do some immediate planning. And often that is, again, in the communication realm. Who is responsible for the communication, how they're going to deliver that message, and how often that message is going to come out. For some of us during COVID, we received a lot of emails, and in some cases, the updates themselves were overwhelming. At Beth Israel Deaconess, we actually, in the radiology department, assign people to curate the emails. So depending on which role, whether it was a resident or a fellow or a faculty member, we actually had a different person assigned to read through the emails, pull out the major relevant points to that individual group, and share that with the group. Also, as part of your planning, you do want to define expectations. If you expect people to come to the hospital in a crisis, they should know where to report. It may be the radiology department, or it may be a specific location, or just their usual workstation. Having some of those expectations communicated ahead of time does help. And again, defining the roles. If there happens to be some additional training that someone's going to need, that should accompany the changes in roles. Next slide, please. So the next point in the cycle, your disaster hits, and whatever that disaster is, you have some type of response. And when that response, when you think about your response, some of that is the immediate response. You may or may not have had time to prepare, but you are responding and dealing with the event in the moment. Depending on the event, you may actually have to work in the hospital, or you may have to work remotely, or you may actually have to evacuate the area, or you may be the area that people are evacuating to, all of which does play into what type of response you would have. Once the crisis is beginning, it is now going to evolve, and there will be some things that you anticipate and some things that are unexpected. And you'll have to look at how that crisis evolves, understanding how long this is going to last, and then adjust your response. But you can think about the demands during a crisis in two ways. The crisis itself or the disaster will generate some of those demands, but your response will actually generate other demands. So if you think about our COVID pandemic, many hospitals increased the number of ICU beds. Many hospitals were able then to take care of more COVID patients. But in doing that, that response of providing more care actually used more PPE, used different types of resources, required different staffing with different skills. So you have both the disaster-generated demands and the response-generated demands, and you have to manage both. Next slide, please. So as your disaster is starting to wind down, there's an opportunity to transition back to either your previous baseline or potentially a new baseline. If you had to leave work, that may involve coming back to the work environment. It may mean a new workflow, either different shifts or different services. You also may find that there was care that wasn't provided during that time, elective care that was deferred, for example. So one of the questions you want to think about is, what steps did you take in your preparation to help you manage that delayed care? Did you collect cases that were canceled or patients who declined to be rescheduled? Did you gather an inventory of the exams or services or referring physicians that you needed to reach back out to? There also are some long-term impacts to consider. If your community actually had power outages, you may need restoration of power before people can return either to their homes or potentially even to work. The trauma of some of the disasters can have big impacts on communities, but also on individuals. If you think about the emotional exhaustion for some of the crisis managers or some of our colleagues in managing the COVID pandemic, there certainly are going to be people who need some support to work through the crisis and may even need support afterwards. And there are examples of both burnout and PTSD that follow crises in healthcare workers, and that we need to be aware of that. You may find changes in clinical practice. You may also see economic impacts, whether it is the loss of revenue or the loss of jobs, or if people's health insurance was tied to their jobs, they may actually now be uninsured but still needing health care, which also can put a strain on both the community and the patient and the health system. Next slide, please. As you look at the mitigation phase, this is an opportunity to reflect back on what you learned from the experience and how could you build capacity or resilience into the processes that you have. Next slide, please. If we just look a little bit at the hospitals, hospitals have an administrator on duty. And if you have a crisis that occurs, the administrator in duty often becomes the incident command center, the incident commander. And what the incident commander does is they launch an incident command center where individuals within that center would have defined roles. Hospitals also are very proactive, often having contracts with the Red Cross or public health in which different roles are defined inside of those contracts. For example, if there are going to be evacuation centers, who would staff them and where would they be? Those are often defined in those types of contracts. What's interesting about this incident command center is it actually is a parallel process. It's not typically going to be the hospital CEO and chief operating officer running the disaster. Often it is someone else who is the incident commander and a separate infrastructure is spun up. Next slide, please. This separate infrastructure is called an incident command center. And this is a standard approach to the coordination of an emergency response. This actually doesn't come from healthcare. It comes from governmental interagency interactions during California and Arizona wildfires. The agencies didn't work well together because their roles weren't defined. It wasn't clear who was in charge. So this system developed out of that chaos, if you will, into a standard approach to how an emergency is managed. The features of this is that it's flexible, it's modular, and it tends to emphasize coordination. So there is an assignment made of an incident commander. And one of the things that occurs is an operations center in a specific location is set up. And then all operational information flows through that center. If you've seen this in a hospital during a hurricane or a snowstorm, often one room in the hospital is set up as the command center or an operations center. And there's a special phone number assigned to that and information flows into that room. In the pre-COVID era, that room would actually have had multiple people with individual assignments sitting in that room and taking phone calls and coordinating efforts. During COVID, because of social distancing, you couldn't put all of those people in one room. So what you saw was one person sitting in the incident command center, and they were connected to other people through phone, email, or video conferencing. Next slide, please. A typical incident command structure would be the incident commander, and then you would have people assigned to be responsible for operations, logistics, planning, administration, and finance. Under logistics, a lot of your supply chain, a lot of the needs assessment and distribution of resources would occur. Under the admin and finance, there's often an inventory made of what's being expended specifically for the crisis. If a crisis or a disaster reaches particular scales, state or federal crisis or disaster designation is assigned, and there may be funds available to help recoup some of the specific costs of managing the crisis. Next slide, please. But incident command centers are actually used in other systems as well, not just in crisis. So if you are at a large event, a concert or a parade, or any other really large gathering, an incident command center has probably been set up in the background and is available to run logistics, to look at any of the unusual costs that occur, and to be able to manage the event in the event of an emergency. Next slide, please. So just to think about for a moment as you think about our workflow in a radiology practice, how would you provide your services if any of these things occurred? You know, the paging system going down, or if you can't actually get into the hospital, staff not available, other failures of systems, whether it's power or phone or PACS. And if that system was down, do you have plans that would allow you to provide services if they were down for a couple of hours, a couple of days, or even longer? Next slide, please. It's easy to get overwhelmed as you think about the number of potential things that could fail, and you can't plan for everything. But one way to look at this is just to think about a few of these common themes we've talked about, like communication. Do you have communication plans in place? Do you have redundancies? Are there some backup plans? What's your downtime protocol? And many radiology practices have very robust downtime plans. What about relationships? You want to make sure that you have established relationships before the crisis begins. You'd like to be able to pick up the phone and contact someone. You want to be able to access your professional societies, but also not just the radiology professional societies. Think about your state and county medical societies and the resources they may be able to help you with, and make sure that you're able to work with your state radiology society as well. Those communities are all communities you can learn from, and throughout COVID, many of those communities were very active in terms of sharing information. And another thing to think about is just your supply chain. Are they things that you have supply chain vulnerabilities? Next slide, please. So as I wrap this up, I want you just to sort of reflect on a couple of questions. In the 2 months before you heard of COVID-19, how often did any topics of disaster planning occur in an agenda for a meeting that you were in? If you think about the radiologist in your practice, how many of them got any credit, any CME in disaster training or related topics in the last 5 years? And if you're hospital-based, your hospital runs disaster drills. When was the last time that you personally participated in a disaster drill in the last 5 years? And if you think about those questions for yourself, think about them also looking at the entire group, because those are all skills that you might want to cultivate in the group. Next slide, please. The Department of Health and Human Services has a public health emergency website, and there's an excellent set of resources available there if you wanted to learn more about Incident Command Center or disaster management. Next slide, please. So the last thing I wanted to share with you is, as you go back to your practices and you're reflecting on what has gone well or not gone well in managing COVID-19, there's an opportunity to learn from that. And the exercise that I'd suggest you try and do is, rather than talking about what worked and what didn't work, I'd suggest you use an exercise and a tool called plus delta. The plus is the things that went well. You acknowledge that they went well, and that if something were to happen again, you'd like those same processes and supports to be in place. The delta is an opportunity that you think you could do better at. It doesn't necessarily mean it was done badly, but you see either a need or an opportunity to improve that. So on the plus side, your practice might already have had workstations at home, and there might have been really good sharing of COVID-19 articles and resources amongst the clinical practice. On the delta side, you might have had too much email. You might have had too over communication. Also, you might not have known where you could have helped when you had time or you had interest in trying to help within the system. You may not have known where to put that energy. So those might have been the types of things you could collect and use that information as you plan for your next disaster. So there's an old proverb that asks when the best time to plant a tree is, and the answer was 20 years ago. The next question is, when's the second best time to plant a tree? And the answer is now. So I think you want to really do your disaster planning now for the next time you have a crisis to face. That concludes my comments, and I thank you for your attention.
Dr. Thorwarth, you have yourself muted.
Not according muted by the organizer earlier.
You're good now. We can hear you.
Okay, great. Well, welcome all, and thanks so much for taking part of your evening to join us in this discussion. I'm going to do the second phase of our program, and then we'll leave some time for question and answers at the end. All of these slides will be available to all of you, so please, if I move quickly through a couple of them, don't worry about that. Okay, just a couple of disclosures. Obviously, I'm employed by the American College of Radiology. I serve in two other organizations, the Council of Medical Specialty Societies. That's a 45 organization, 45 specialty society organization with about 800,000 physicians represented, and then the Specialty Society CEO Coalition. But going to Jim's point earlier, that gave us a great opportunity to coordinate with other societies. But also, I really want to disclose how proud I am of the response that the American College of Radiology leadership, our volunteers, and our staff to this truly unprecedented challenge of COVID-19. My section, my objectives are to describe really that crisis management is very much like change management, only it's faster and obviously potentially higher consequences. Then I want to tell you a bit about the story of how the ACR responded to COVID-19 from a number of different perspectives, and we continue to guide and serve our members and their patients. And then discuss how we should, quote, never let a crisis go to waste. And that's, for Jim's point, you don't want to come out without having learned a lot of lessons. President John Kennedy said in a speech, when written in Chinese, the word crisis is composed of two characters, one representing danger and the other opportunity. And we really need to approach these crises as both. And also a great quote from Jim Collins that we can count on the fact that uncertainty is permanent, chaotic times are normal, and change is accelerating, and instability will likely characterize the rest of our lives. So again, my congratulations to all of you for attending this evening in order to be ready for that future. In the ACR strategic plan, we define our core purpose. That is, why does the ACR exist? To serve patients in society by empowering our members, all of you, to advance the practice, science, and professions of radiological care. And I think any organization has to look to their core purpose even in the time of crisis. John Cotter is thought of as sort of the father of change management, and I really recommend this book to any of you who haven't had the chance to read it yet, but let me go through a couple of his stages of change management. He divides it into 8 steps, and I'll go through each of these individually. Some of these obviously are much more applicable during a crisis, but you want to think of the sequence, and again, it happens a lot more quickly in a crisis as you go through the changes. Yep. Next slide. There's really not a problem in a crisis to establish urgency. The burning platform is whatever the crisis may be, and Jim, of course, described a number of those. But you want to be sure you understand the nature and the severity of the crisis right from the start, as best you can predict. It won't be absolutely accurate, but you want to really understand that first. You want to make sure as a leader in crisis that you have a calm tenor and avoid panic. And you cite past successes to encourage your team to be sure that you're ready and able to address the challenges. And particularly, as Jim mentioned, that the preparation that you've done before this all began. Then building a response team. Again, whether you call it by any title, it has to have the same characteristics and the same function. It's got to be a group of credible individuals that have a conviction to the response. You want to have a mix so that there's real wide representation within that group. And you need to, again, as I said before, a steady-handed demeanor. You don't want to act as a group with your hair on fire, because that certainly won't inspire confidence in your staff or in anyone who's involved in the response. Then you want to develop the vision and the strategy as you enter into this response phase, as Jim described it. You want to be sure you have a clear, concise vision of what you want it to look like as you progress through this. You want to define the key reasons for that response and make sure you're communicating those accurately. And you want to be sure that you're showing them a future that is achievable. If it is too far reaching, you really will have a hard time getting your team on board. And then you want to select the immediate and short-term goals as you undergo this change. You don't want to be this fellow who's stranded on the island who didn't quite get his message correct, and therefore his rescue team says, oh, wait, cancel that, I guess it says health. So then the next point is, and this can't be overemphasized, that you really communicate the response vision to your entire team, and that you have your leadership group all openly, honestly, and frequently, that's really key, frequently addressing the crisis. You want to describe the stages of the planned response and execution. You have to have a sort of elevator speech, because you're not going to have long times to make these explanations. So be sure you've got that in order right away. Be prepared, because there are going to be questions, anxieties, and concerns, and you want to be sure that you're ready to respond to those. And then, as a leader in this response, you want to be sure you've exemplified the conviction that's necessary to get through that. You want to be sure that you've empowered those so that they're not standing around waiting for you to make all the decisions. You want to identify the network of those who are clearly engaged and willing and ready to step up. Promote the innovation in line with the vision of the response. You want them to be looking for solutions that are creative in order to get there. Recognize that and reward those, particularly in the early going, so that you excite those and empower them to feel very much engaged in what you're doing. Identify and counsel those who are slow, and quite frankly, if there are people that aren't getting on board, you might as well just tell them to get off the bus, and the response team goes on without them. And you want to be sure that you remove any barriers to the response as far as making sure there's not things in your structure, your information technology that impede the response to the crisis. Again, moving through the next phase, you want to be sure you celebrate, even though it seems like you're head over heels involved in responding to the evolution of the crisis. You want to take those moments to celebrate the successes, and again, that'll maintain the enthusiasm of your group as you address this. Demonstrate how the quick response has really positively impacted other elements of the organization, not just within their particular department or silo. And then again, as these changes occur and as you've addressed these challenges, you want to be sure to incorporate and consolidate those as you continue to move ahead. Again, showing how you're assisting each other through this, and that again really involves the entire team. And then, as Jim said, you want to evaluate what went wrong and what went right, even during the crisis, so that you're learning as you go and building on the momentum, particularly of those successes as you face the new challenges. This is all part of a continuous improvement or a culture of a continuous improvement. You want your organization to exhibit the so-called kaizen and that's been so notable in the Japanese responses. And then once this is, and you get into the phase as Jim described as recovery and mitigation, you want to anchor those things that you've learned so you continue to talk about the successes and the results and improvements. You want to review your strategic plan. How does that need to be revised in order to make sure you're ready for whatever crisis might face you in the future, and then incorporate the new values and expectations, because this is really important in your recruiting and hiring, that you bring people on board who have these talents. You don't simply want at the end of a crisis to settle back into your old ways and not have benefited and taken, as it said, it's an opportunity as well as a challenge. So let me shift gears and now talk about how the ACR went through this. In February, clearly there was rising awareness across the country of COVID, and the resulting anxiety in our staff was real and palpable. Our EVP group became our, if you will, response team and began brainstorming about the what-if scenarios. Again, we reviewed our policies in past responses to other crises. We updated our epidemic policy, which we had, but it needed fine-tuning in anticipation of this one. We wanted to make sure that all the prior crises had been short-term, such as major storms, but this one might last a good deal longer, and that none had seriously threatened staff health, which this clearly did. We looked at the existing infrastructure and identified potential gaps and tried to get those gaps covered very quickly in order to be ready. And then in March, I will say that we were very fortunate to have just renewed our staff operating principles. And I'm not going to go through each of these individually, but these really became a cornerstone for the staff portion of the response to COVID. We are one team. We're curious. We listen, care, and are thoughtful. And again, these 5 elements really played a big part in our staff response. In early March, we had very concrete preparations in place. We had stress tested our systems. So in the midst of converting, we were in the midst of converting to Microsoft Teams. So our entire IT staff, and that's over 100 people, one day worked entirely from home as a test of that system and the use of the system. We were planning for an all staff work from home day, but unfortunately, as I'll mention in a minute, we didn't have time to do that stress test. We were examining vulnerabilities that came out of that test and then reviewing our existing experience, such as our Philadelphia group, the Center for Research and Innovation, works about 85% of our staff there work from home full time. So we had some experience to use. We were looking at a major renovation in our building, and we've done some planning for that. So again, that gave us a real head start on these possibilities. And then we had data from our staff surveys on the attitudes of working from home. So there was a major emphasis during this entire time in early March on communication and reassurance of the staff that we would step up to the challenge, however it faced us. So we had a Sentinel event on March 15th, and that is a staff member who had traveled to a subspecialty meeting was informed that someone on their flight or in his flight home from that meeting had tested positive for COVID-19. This made this a very concrete episode for us. We had called an emergency meeting of the EVP team, which, as I told you, was sort of our command center. And we had data gathering on the potential exposure to other staff related to that worker and make sure we knew exactly who he had been in contact with since his return. So immediately on March 15th, we made a midday decision to release all of the staff to work remotely from home. We had done this on short episodes before for major snowstorms or other episodes, but never with an open-ended release like this was. The primary considerations in the very early going were how make our staff fully capable and to safely manage full work expectations at home, both for our members, for any external stakeholders. And this meant that they had to have full technical support. All of them, of course, were instructed to take their laptops and computers with them. We needed to make sure that at home we adhered to certain requirements, OSHA requirements, and we had to make sure that our staff members fed back to us any shortcomings that we would need to help them with. We made sure that we had robust communication channels both within the ACR and with external stakeholders, and then we had to provide guidance to members and others on the appropriate and safe clinical care delivery, which of course we put out on the ACR website for all of you and your practices to follow. And next. So again, we had locations in Virginia, Maryland, District of Columbia, and Philadelphia, 4 separate offices, and we had employees in 21 states. So we had to be very cognizant that different rules were being issued by different governors or mayors, and the shelter at home orders had different implications in those different sites. Our Center for Research and Innovation, and this is the picture of the 2 Liberty Place tower where that office is housed, they, as I mentioned, had remote workers and a long experience, but the rest of the ACR had only mild experience, with most remote workers 1 to 2 days off-site. But converting to a full work from home, and this shot of a similar office with empty cubicles, we flipped the switch on March 15th, and this is exactly what our office building looked like. Our message to our staff was that their safety was priority #1 for all of us, and that we wanted this to be seamless to our members and any external stakeholders. We were successful due to honestly remarkable work by our information technology and informatics group, as well as support from a very, very adaptable staff. We tried to keep a sense of humor, and we tried to, again, I mentioned the tenor is very important. This cartoon on the left of a worker at home, how she dealt with childcare, and this one on the right who said quarantine with hubby for 2 weeks, and Gertrude is knitting something special for him. Obviously, there were significant challenges that all of us had to face. The COVID response activities are too numerous for me to mention, but it was across the ACR, utilizing all the staff as well as the volunteer commissions, committees, and infrastructure, taking advantage of all their capabilities. As far as external facing, we had to make sure we tapped into credible resources, things like CDC, and we had to follow them religiously, World Health Organization and others. We worked with approximately, believe it or not, 150 other national and state medical associations, including non-physician provider groups, government, and industry. You've seen, I hope, on our webpage, very early on, we issued the clinical resources for radiologists, and this was continuously updated, not only using that which the ACR did, but using from other radiology sources, but also from other medical specialty societies, the Society for Critical Care Medicine or pulmonologists, who put out issuances that were very, very helpful to all. And then, of course, there was the packages that were put together by the federal government in response in order to support people in their practices. So we created, next slide, a second portion of that website. And this was for just members that dealt with the economic and regulatory updates for radiologists. So all of our members could take advantage of those relief packages and make sure that they were fully informed. And next. We had to turn our annual meeting that was already scheduled for May into a completely virtual experience, and I hope many of you got a chance to participate and attend May 16th through 19th, and under the capable hands of our speaker, Rich Duzak, and Vice Speaker, Amy Kotzinis, we were able to turn our meeting virtual in just 6 weeks' time. Again, huge undertaking and successfully achieved. We wanted to be sure we were supporting the trainees. We knew that many of the trainees were actually redeployed into non-radiology clinical areas for which they might face real challenges. We wanted continuous professional improvement modules available to them so they could continue their radiology education even during times when it was tough to do teaching within the academic centers. Our Radiology Teaches program, originally designed for medical students, we obviously created a COVID module because we wanted to continue to convey those messages. Our Patient and Family-Centered Care Commission, which Jim Rawson had chaired, we wanted to be sure they put together a communication curriculum for both the practices as well as patients. And then we collaborated with other organizations such as the Program Directors in Radiology, Lung Cancer Screening Education with the Lung Cancer Alliance. And then, of course, we knew the training exams had to go on to be sure that the trainees were supported. Next. Promoting safety was a cornerstone, and we issued a joint letter with the Society of Radiologic Technologists, the Registry for Radiologic Technologists, ultrasonographers, nuclear medicine technologists, and others, that they be provided with full PPE. We had a joint letter with the program directors and the ACGME in support to be sure all received PPE as to their needs. Next. But the innovation can't stop just because you're in the midst of a crisis. In fact, this was the opportunity. So we developed, using our so-called triad infrastructure that's connected to 19,000 facilities around the country, we developed a COVID-19 registry that could collect real-time data to assist in developing research projects so that you could get improvements in care literally on the fly. And then working with our quality and safety to be sure that those who participated in that actually got MIPS credit with Medicare in order to show that they were actively participating. And next. We wanted to continue to support our chapters, not just the annual meeting, but making sure that they were kept up to date through executive update resources, and also exploring the potential, which is now being put in place for their virtual meetings, also our platform from the annual meeting to be used to enhance the chapter meetings as well. We want to take the next steps and look and be ready for the future. So the constant communication that I've emphasized through this talk, and the early and repeated surveys of our staff that we continue to do in order to be sure they're doing well and we're keeping up to date with their needs, we've now actually projected to our staff that we're not going to return to the office or restore access to the office until at least the end of 2020. We know that COVID's still going to take a time, and until so-called vaccine day comes along, there will be many who are reluctant to come back into the office. We've made sure that they understand that we're going to be flexible and be able to personalize those decisions for people with either family members with immune compromise or some reason that they have special circumstances. And we have already put together a team that has designed our office function in order to operationalize the safety precautions and measures that need to exist. Next. So again, returning to that crisis two-character demonstration of danger and opportunity, I think the ACR, both staff and volunteers, what will the ACR post-COVID look like? We're looking at this as an opportunity to be sure that we're fully capable in the future. And next. So my thanks to you for your attention, and now I'll turn it back to our moderators, Doctors Nathan and Pyatt, for some questions and answers. Thanks very much for your attention.
Well, thank you, Dr. Rawson and Dr. Thorwarth, for your expertise and excellent and informative presentations. So as Dr. Thorwarth just mentioned, we're going to now start the Q&A session. So just a reminder, there's two ways that you can ask questions. You can type it in that box in the lower part of the panel, or you can raise your hand. And it does look like we already have a couple hands raised. So Dr. Pisakia, I unmuted you, so you just need to unmute on your end now. Oh, Dr. Pisakia, can you unmute on your end? Let's see. Kat, could you unmute Dr. Pistakia? So it says you're self-muted, Dr. Pistakia. Is there any way that you could unmute?
Ted, while we're waiting, perhaps we could go to any questions that came in on chat line.
Let's see. I don't see any questions here, but let me try Dr. Weissman. Dr. Weissman, I unmuted you. Are you on the line?
It looks good, Jen. Can you hear me?
Yes, I can hear you.
Great, thanks. Hey, Bill and Jim, I really enjoyed your presentation. I learned a lot. I had some questions. Have any of you, observed some situations over your careers that have not worked so well in the situation, repeated errors that you've seen over time that kind of stuck with you and you said, gee, people should really know about this and not make these mistakes? I'd be curious to know what you've experienced. Thanks.
Jim, you want to go ahead?
So thanks for the question, Ian. I think when you look at crises, you do tend to see some patterns. And I think sometimes the pattern I've seen has been some communication failures. Sometimes we can't get a message out fast enough or broadly enough. Or when we do get a message out, we don't have enough information. So I think that one of the things that I would sort of take away from the things I've seen over time is that getting a message out and acknowledging uncertainty is okay, and then following up with more information as you get it, but not responding and waiting until you get all the answers leaves people without any answers or any clear guidance of what to do.
Thank you.
Ian, I couldn't agree more. I think communication, again, going back to my comment about it's got to be frequent. It's not, and the second, I had one experience actually in a hospital, in one of the hospitals in which I worked, where quite frankly, the hospital administrator and leadership team really got into a frenzy, and avoiding the kind of hair on fire appearance goes a long way into calming and calming the response and making it much more organized.
Okay, so I have, so I think there's a comment here. Great talks, thank you. I appreciate the idea of preparing someone in the group to be a point person who specifically focuses on crisis management and liaison with the hospital. Can I ask for other crises for us to be thinking about?
I think depending on where in the country you live, you probably have your own unique natural disasters that tend to come. They probably don't approach the scale that we see in COVID now, but that's okay. We have the opportunity, I think, in the northeast of the country. You certainly have plenty of snowstorms. Along the eastern seaboard, you'll see hurricane season. Other parts of the country have weather disasters with tornadoes or fires or earthquakes. I think natural disasters are a very reasonable thing to look at geographically and think about how to prepare for. The other thing that I think is helpful is if you look at your community, what's in your community that could potentially be a risk? If you have industry or you have a lot of transportation, trains or highways in your community, those are potential areas where there can be problems. And just thinking about how you might respond to them. If you had an industrial accident, or if you had a major highway transportation accident, or accidents at airports. Bill, do you want to add to that?
No, I think you've really hit the list, Jim. I can tell you, for instance, if you look back at Harrisburg, Pennsylvania, and the 3 Mile Island incident, or if you look at being aware of and knowing what's in your region and to what you might be subject. Again, things as you say, major transportation conduits. You're near a major commercial airport. Those types of things would define the less than natural incidents that might create a crisis.
When I lived in Georgia and there were some bad hurricanes that came up the coast, one of the challenges that we had along the South Carolina and Georgia coast was that wildlife that would have been in particular areas was displaced. So when the linemen came in to restore power, when they saw water that was a foot or two deep, they didn't know what was in the water because we had alligators.
And
Back in
snakes.
Boston, I haven't had that problem during snowstorms or other crises, but there are very regional differences that you should look for and be able to be prepared for.
Okay, next question is from Srini. How do you manage dissent in the ranks? This crisis has been heavily politicized, and even people who are scientifically well-versed question common sense approaches.
I'll start it off. Quite frankly, and I've seen this as far as mask wearing and other things, you have to accept that there are limitations to what you can accomplish. And I think one of the keys is don't get so frustrated with that you don't attend to the things where you can have an impact. I think relying on good scientific evidence is going to be a cornerstone of in healthcare of response to any type of crisis, and stick to those sources. And those sources may change. We saw, for instance, the CDC in the early going not recommending masks, routine wearing of masks. And at that time, I think there was a real concern about the PPE supply for those healthcare workers on the front line. And also there wasn't really good evidence. But the key is to continue to monitor those sources and evolve with them. Don't get stuck in one fixed phase of the response.
Yeah, I think what's helpful sometimes when you have dissent is to acknowledge that dissent is helpful because we can examine the multiple sides of an issue, but also to remind people that we have some common purposes and that we want to make our decisions in a way that reflects our values and what we're trying to do. And we're in healthcare and we take care of people. So if we stay focused on taking care of people, that often will still have dissent, but you can also often reach consensus around that common value.
Yeah, and I'll just go back to one comment I made in the talk is there will be people who, quite frankly, just aren't going to get on the bus. And you have to accept that and make sure that you garner the troops who buy into the mission and buy into the culture and reinforce their activities.
Okay, next question. Any suggestions for helping convert from the short-term response to the long haul?
Go ahead, Jim. I'll give you the first shot.
I think when you ask questions about what are short-term fixes, it's helpful to think about whether they have some long-term implications. And I think you talk about both. And the sooner you begin to talk about long-term consequences and how you want to anchor those into practice and how you want to anchor short-term changes into the practice, the more likely they are to actually stay there. But I think you have to have that conversation. There are things we've done in our practice that we've said, this is temporary. We just don't know how long temporary is. And other things we've said, this is a change. This has some advantages. We're going to be doing this going forward. We haven't figured out how it's all going to work, but we will. And so I think being honest about what you see as advantages and disadvantages, and also looking at this as just being a very long, continuous quality improvement process.
Yeah, no, I think that's exactly correct. And I think just to go back, realizing this is not an abrupt line where you change from short term to long term. It's going to be an evolution of the response, and I think that continuing to celebrate those early successes as you transition to more longer term planning will keep your folks on board.
And just to Bill's point about celebration, I think one of the challenges that a number of people have found is where at one point we might have brought in food to a department or a practice to thank people. We're now trying to not have them eat together.
Mhm.
where at one point we might have taken people out to dinner. We're, again, socially distancing. And so I think there are some challenges, and we really have to make efforts to say thank you to people. And sometimes that's an email or a card or dropping by a work area or calling someone and just thanking them. But I think the celebration is something I think we could do a lot better at.
Yeah, I'll just mention one other thing. I talked about frequent communication. The frequent communication shouldn't drop off as you move into the longer term success or longer term changes. You want to be sure that people don't get the sense that you say, okay, it's over because we're not hearing from the leader X or leader Y. Make sure that you keep up that pace.
Yeah.
Okay, so I think we have time for one more question. COVID-19 is a national security crisis. How is ACR preparing to deal with other similar crises in the future?
Well, I'll say first and foremost, we're hoping there are not many similar such crises. But I do think that we have learned an awful lot, both from the standpoint of the teleworking. I do think that we've learned a lot from feedback we've gotten from external stakeholders of what the challenges were that we can address more smoothly. But I think that again, if we had a crystal ball, we knew what the crisis was going to be. Yeah, we can put together a plan, but we have to expect that, as I said from the Jim Collins quote, there are going to be disruptions, and I think that we need to be sure that we're looking at the broad principles of our response more than these specific individual measures. Jim?
One of the things that ACR did way before COVID was actually talk about potential disasters. And we built out scenarios and we talked about what would happen. And what was really impressive is as we built scenarios out and talked about them, we found we had a lot of the pieces in place to be able to respond. And as Bill said, we might have needed some fine tuning, but we had some of the pieces in place. And so having a mindset that says, what would happen if? How could we be better prepared? And we had those conversations way before COVID, and I think that helped because we'd had discussions, we'd considered where there might be gaps, we had talked about what things might need to occur, and I think that mindset made us much. It prepared us, and I think
Totally
it prepares
agree.
us for the next disaster.
Okay, so it looks like we're a little over the hour, so I want to be respectful of everyone's time this evening. So I'm now going to turn things over to Dr. Pyatt to conclude the webinar.
Thank you, Jen. We'd like to thank everyone for attending this evening's webinar. If you have any other questions, please contact the RLI at rli@acr.org. Please note that you will receive a follow-up survey in the next few days, and we would appreciate it if you could complete that survey and provide your feedback. You will also receive a link to view a recording of today's webinar. The next Power Hour webinar will be on corporatization, the corporate perspective, and it is scheduled for Thursday, October 22nd at 7 p.m. Go to www.acr.org/powerhour to register for this and other webinars in this series. If you've enjoyed this program and want more leadership training, the RLI has a plethora of options available for you at acr.org/RLI. You don't have to be a department head to be a leadership. Leadership is for everyone. On behalf of the RLI and our presenters tonight, thank you for joining us and have a great rest of the day and evening. Good night.
Good night. Stay healthy, everyone.
Good night.